Subarachnoid hemorrhage. It means bleeding into the subarachnoid space, which is the space between the pia mater and arachnoid membrane. Etiology: spontaneous and traumatic. Spontaneous: rupture, hemorrhage, hypertension. Rupture: intracranial aneurysm, perianeurysm. The most common non-traumatic cause in 80% of the cases: congenital atherosclerosis, mycotic, and subbacterial endocarditis. And then we have intracranial AV malformation. I'm sorry, it's not subbacterial, it's subacute bacterial endocarditis. Intracranial AV malformation, hemorrhage in a brain tumor which extends to the subarachnoid space, or hemorrhagic blood disease such as purpura and hemophilia. Then hypertension, traumatic, head trauma. The commonest cause of subarachnoid hemorrhage are head trauma, rupture of an intracranial aneurysm. Incidence: age from 40 to 60 years in cases of aneurysm and from 10 to 20 years in cases of AV malformation. Clinical picture of intracranial aneurysm and clinical picture of the SAH or subarachnoid hemorrhage after rupture of the aneurysm. The clinical picture of the aneurysm: we have silent, compression, and rupture. Silent: it may remain silent without any manifestations. Compression: it may compress neighboring structures such as internal carotid artery aneurysm in the cavernous sinus. It compresses cranial nerve 3, 4, 6 and ophthalmic division of the 5th nerve, leading to ophthalmoplegia and facial pain, while basilar artery aneurysm leads to compression of midbrain and pons, cranial nerve palsies, long tract manifestations such as hemiparesis. Rupture: 90% of the cases present when they rupture, giving clinical picture of the subarachnoid hemorrhage. Rupture may be precipitated by strain, stress, severe cough, or sexual intercourse. Clinical picture of the subarachnoid hemorrhage after rupture of the aneurysm: we have features of increased intracranial tension, features of meningeal irritation, features of cranial nerve affection, features of eye affection, and finally, features of cerebral affection. Features of increased intracranial tension: headache, vomiting, papilledema. Headache due to irritation of the meninges by blood. Onset: sudden. Character: severe, the worst headache in the life, and this is a very important description. It increases by flexion of the neck. Site: starts at the back of the head, upper neck, then generalized. Reference to the shoulders, back, limbs. Headache is the most common symptom of subarachnoid hemorrhage in 97% of the cases, and it's described as thunderclap headache. Vomiting and papilledema. Features of meningeal irritation: meningismus, pain, neck, body, and positive signs of meningeal irritation. Pain due to irritation of the spinal sensory roots, in the back of the neck, shoulders, and upper limbs, in the lower back and lower limbs. Neck rigidity. Body opisthotomous, high arched back. Positive signs of meningeal irritation are Kernig signs, Glasgow signs, and Kernig sign: while the hip and knee joints are flexed at 90 degrees, extending the knee is limited and painful due to stiffness of the hamstrings. Glasgow sign: while the hip and knee joints are fully extended, raising the leg by flexing the hip is limited and painful. Prudence sign: neck sign: passive flexion of the neck leads to flexion of both hips and knees. Leg sign: passive flexion of one hip leads to flexion of the other hip and knee. Features of cranial nerve affection: pressure by blood. The most commonly affected nerves are the ocular nerves 3, 4, and 6, and the optic nerve 2. Features of eye affection: flame-like retinal hemorrhages due to blood in the subarachnoid sheath of the optic nerve. Papilledema due to increased intracranial tension. Features of cerebral affection: confusion, coma, cortical sensory loss, convulsions, contralateral hemiplegia, contralateral homonymous hemianopia, aphasia. Investigations: to establish the diagnosis, CT scan, the first investigation to be done. Non-contrast CT scanning reveals the diagnosis in more than 90% of the cases if performed within 24 hours of bleeding onset. If bleeding is detected, the diagnosis is established and lumbar puncture is not needed. CSF examination: lumbar puncture is mandatory if there is strong suspicion of subarachnoid hemorrhage despite normal CT. High pressure: aspect grossly bloody that doesn't diminish in successive tubes. Cells markedly increased. RBCs, proteins markedly increased. Glucose and chlorides are normal. Organism culture is negative. To detect the cause: digital subtraction angiography, the gold standard to detect intracranial aneurysm and define their location. CTA and MRA, CT angiography and magnetic resonance angiography, alternative non-invasive tests, but they don't achieve the resolution of DSA, which is the digital subtraction angiography. Complications: rebleeding associated with worse prognosis, vasospasm causing cerebral ischemia or infarction, hydrocephalus due to occlusion of the CSF flow by blood, seizures due to cortical irritation by blood, increased intracranial tension, hyponatremia due to SAH, hypothalamic injury, myocardial injury due to centrally mediated release of catecholamines within the myocardium due to decreased perfusion of the posterior hypothalamus, leading to left ventricular dysfunction, increased brain natriuretic peptides and troponins. To differentiate SAH from traumatic spinal tap, differential diagnosis, other causes of coma, other causes of intracranial hemorrhage, meningitis, causes of hypertensive emergencies and causes of thunderclap heading. Treatment, critical care management and aneurysm treatment. Critical care management, monitoring, constant hemodynamic and neurological monitoring, ICT, ventriculostomy in appropriate patients, direct measurement of the ICT, drainage of CSF when appropriate. Patients without ventriculostomy can be managed medically with osmotic therapy and diuresis. Blood pressure control, it should be treated as hypertension emergency. Guidelines, decrease the systolic blood pressure to less than 160 mm mercury is reasonable. Don't use nitroprusside or nitroglycerin. Use nicardipine and labetalol, the value to decrease the risk of rebleeding, but it increases the risk of infarction. Seizure control, AEDs, decreases the seizure, anti-epileptic drugs, decreases the seizures but may worsen the cognitive outcome, especially phenytoin. Antifibrinolytic therapy, tranexamic acid and epsilon aminocaproic acid, they delay clot lysis, prevent rebleeding, however they may increase the risk of cerebral ischemia. Aneurysm treatment, invasive intervention, aneurysm repair. Re-rupture is associated with mortality that is estimated to be 70%. Aneurysm repair is the only effective treatment to prevent this occurrence. It should be performed within 24 to 72 hours whenever possible. Surgery, direct surgery to the aneurysm, surgical clipping, minimally invasive technique, endovascular coiling. Tiny platinum coils are threaded through the catheter, deployed into the aneurysm, blocking blood flow into the aneurysm and therefore prevent rupture, prophylactic, or reduce bleeding, which is therapeutic. Medical treatment indications when invasive intervention must be delayed or when it's not possible. Non-surgical cases, hemorrhagic blood diseases, difficult surgical cases, multiple aneurysms or huge inaccessible aneurysms. Measures, avoid precipitating factors for rupture, analgesics to relieve headache and lumbar puncture in severe headache. Treatment of complications, vasospasm, nimodipine orally or by nasogastric tube, hyponatremia, isotonic saline. Meningitis, inflammation of the meninges, especially the periarachnoid. Etiology, infective and non-infective. Infective, acute purulent meningitis, septic meningitis. The CSF contains mainly polymorphs due to infection by organisms which form pus, meningococci, streptococci, pneumococci, and H. influenza. Subacute lymphocytic meningitis, aseptic meningitis. CSF contains mainly lymphocytes due to infection by organisms which don't form pus, such as TB, fungi, Cryptococcus, and mucormycosis. Viruses such as HSV, HIV, enteroviruses, ecoviruses, Coxsackie, mumps. Non-infective, inflammation of the meninges in the absence of infection due to inflammatory diseases, SLE, rheumatoid arthritis, Behçet syndrome, sarcoidosis, sensitivity to some medications, ibuprofen, and substance injected to the SAH, anesthetics, or radiopaque dyes. Then we have meningococcal meningitis, acute cerebrospinal fever. Etiology, causative organism, meningococci, source of infection, nasopharyngeal carriers, mode of infection, droplet infection. Pathogenesis, nasopharynx after infection. The organisms localize in the nasopharynx, causing catarrhal inflammation. Blood, the organisms then invade the blood, leading to short meningococcemia hours, which may be severe and cause fulminating type. Meninges, from the blood they reach the meninges, purulent exudates, which collect in the subarachnoid space, causing meningitis. The organisms may be localized in the adrenals, acute adrenal failure, or skin, leading to skin rash. Clinical picture, symptoms, signs. The classic triad consists of fever, neck stiffness, others, headache, acute severe, and vomiting. Signs, general signs. Pyrexia, acute fever, high fever, 39 to 40 degrees Celsius. Pulse, tachycardia, except in cases of increased intracranial tension, we have bradycardia. Photophobia, oversensitivity to bright light, and papular skin rash. Features of meningeal irritation, meningismus, pain due to irritation of the spinal sensory roots in the back of the neck, shoulders, and upper limbs, in the lower back and lower limbs. Neck rigidity. Body, obifotenus, high arched back, positive signs of meningeal irritation, Kernick signs, Lasgo sign, signs of neurological deficits, confusion or coma, convulsions, transient cranial nerve paralysis due to exudation around the nerves, focal neurological signs, hemiplegia, which is rare, clinical types, acute meningococcal meningitis, fulminating type, and chronic meningococcal meningitis. Fulminating type, death occurs from marked septicemia before meningeal symptoms appear, Waterhouse-Friderichsen syndrome, and multiple organ failure. Waterhouse-Friderichsen syndrome, massive bilateral adrenal cortical hemorrhage leading to a Dicinian crisis and death, multiple organ failure, such as septicemia, DIC, and ARDS, acute respiratory distress syndrome, chronic meningococcal meningitis. Complications, we have neurological, hydrocephalus due to occlusion of the CSF flow by the organized exudates, seizures due to cortical irritation by pus, cardiac pericarditis, endocarditis, eyes, conjunctivitis, keratitis, rhidocyclitis, and maybe blindness, ears, deafness due to affection of the 8th cranial nerve, others, arthritis, nephritis, or orchitis, and finally fulminating type. Investigations, CT or MRI for the brain, CT scan of the head before the lumbar puncture should be performed in adult patients with suspected bacterial meningitis who have one or more of the following risk factors: immunocompromised state, history of CNS disease, new onset seizure, papilledema, DCL, focal neurological deficit. Patients with these risk factors should have CT scan to identify possible mass lesion and other causes of increased intracranial tension. For the fear of cerebral herniation during the lumbar puncture, CT scan has an additional value to exclude subarachnoid hemorrhage. CSF examination is a cornerstone of diagnosis. Findings: pressure high, aspect turbid, purulent, cells markedly increased, especially polymorphs, proteins markedly increased, glucose markedly decreased, chlorides moderately decreased, organism detected by gram stain or CSF culture. Contraindications, they are relative. Although there is no absolute contraindication to perform lumbar puncture, caution should be used in patients with possible increased intracranial tension, bleeding tendency, suspected spinal epidural abscess, CBC, leukocytosis with shift to the left, increased ESR and CRP, culture of the blood for cases complicated with septicemia, differential diagnosis, subarachnoid hemorrhage, sudden onset, CSF is bloody with negative culture and sugar chloride are normal, CT scan reveals the hemorrhage, encephalitis and brain abscess, presence of parenchymal involvement, cerebrum, brainstem, cerebellum, CSF normal glucose and chloride, acute infections with cerebral symptoms, typhoid, absence of signs of meningeal irritation, characteristic clinical picture of the acute infection, other causes of meningitis, other causes of acute septic meningitis, strep pneumonia, H. influenza, differentiated by CSF culture, viral meningitis, benign course, CSF is clear with normal chloride and glucose, high protein and lymphocytes, TB meningitis, gradual onset, features of TB toxemia, features of primary TB focus, meningitis, minimal signs of meningeal irritation, CSF, typical CSF findings. We have high pressure, cloudy aspect, increased cells, especially lymphocytes, markedly increased proteins, moderately decreased glucose, and markedly decreased chlorides, organism detected by ZN stain or culture. Treatment: prophylactic, isolation of the patient, chemoprophylaxis, rifampicin, 600 mg 2 times per day for 2 days for contacts, immunoprophylaxis, meningococcal live attenuated vaccine, curative, antibacterial treatment. Once meningitis is suspected, we should start treatment immediately, even before culture results, cefotaxime or ceftriaxone, crystalline penicillin, and chloramphenicol, corticosteroids in severe cases, Waterhouse-Friderichsen syndrome, and in case of TB meningitis under cover of anti-TB drugs. Encephalitis, inflammation of the brain substance, etiology, primary and secondary. Primarily attacks the CNS. Neurotropic viruses attack the nerve cells, polymyelitis, rabies, and pantropic viruses attack the neurons, arthropod-borne viruses. Secondary encephalitis, they don't primarily attack the CNS, viral, herpes simplex, herpes zoster, EBV, CMV, mumps, measles, bacterial, typhoid, bacillary dysentery, parasites, malaria, others, mycoplasma, chlamydia, and rickettsia. Clinical picture: manifestations of parenchymal involvement, focal or diffuse, cerebrum, coma, aphasia, convulsions, hemiparesis, brainstem, cranial nerve palsies, long tract manifestations, cerebellum, ataxia, dysarthria. Manifestations of slight meningeal irritation may be present. Manifestations of viral infection: general, fever, headache, myalgia, malaise, specific. We have, depending on the causative virus, lower motor neuron lesion paralysis with fasciculations in poliomyelitis, parotid swelling in mumps. Investigations, we have imaging CT and MRI of the brain. EEG is helpful. Treatment, antiviral agent acyclovir. Coma. Definition: state of profound unconsciousness from which the patient cannot be aroused, even by powerful stimuli. Physiological aspects: the state of consciousness normally depends on intact cerebral cortex and intact reticular activating system. Intact cerebral cortex: the cerebral cortex receives activating impulses from the RAS. The RAS sends activating impulses to the whole cortex. It's a group of nuclei situated in the brainstem, receives stimulatory impulses by pathways carrying arousing sensory input from the surroundings. Disturbed consciousness level, or DCL, may occur due to lesion in the cerebral cortex. The lesion should be extensive to produce coma. Lesion in the reticular activating system: small lesion is enough to produce coma. Then we have the grading of consciousness level. According to the Glasgow Coma Scale, the general grading level of consciousness is recently done according to the patient's response to external stimuli. We have 3 criteria. For eye opening, 4 grades. Verbal response, 5 grades. Motor response, 6 grades. For eye openings: none, 1. In response to pain, 2. In response to speech, 3. Spontaneous, 4. For verbal response: none, 1. 2. For sounds: no words. 3. Words, no sentences. 4. Confused. 5. Oriented. Motor response: none, 1. Extending to pain stimuli, 2. Flexing to pain, 3. Withdrawal to pain, 4. Localizing the pain, 5. And obeying orders, 6. According to the Glasgow Coma Scale, coma, complete loss of consciousness with eye opening, none, 1. Verbal response, none, 1. And motor response, none, 1. So the total score would be 3. Normal consciousness or alertness, complete consciousness with eye opening, spontaneous, 4. Verbal response oriented, 5. And motor response obeys orders, 6. DCL, disturbed consciousness level, with eye opening variable, verbal and motor are variable as well. It ranges from 4 to 14. Etiology: intracranial and extracranial. Intracranial causes: local causes in the brain, traumatic, head injury, cerebral concussion or contusion, laceration, inflammatory, encephalitis, meningitis, brain abscess, neoplastic brain tumor, epilepsy, vascular, hemorrhage, cerebral or subarachnoid thrombosis, embolism, hypertensive encephalopathy. Extracranial causes: general causes with secondary effects on the brain, toxic, metabolic, toxic, aspirin, poisoning, fever, bleeding tendency, hyperventilation and vomiting. Alcohol intoxication: characteristic mouth odor, flushed face and conjunctiva with increased blood alcohol. Barbiturate poisoning: respiratory depression, circulatory failure, and increased blood barbiturates. Belladonna or atropine poisoning: fever, hot flushed dry skin, dilated pupils, tachycardia. Carbon monoxide poisoning: cherry red skin. Morphine or opiate poisoning: pinpoint pupils, respiratory depression, hypothermia, and bradycardia. Metabolic encephalopathies: the term metabolic encephalopathies was elaborated by Kinnear Wilson, and there are information about this scientist. They are not important. Organ failure: respiratory failure, hypercapnic encephalopathy, hepatic failure, hepatic encephalopathy, renal failure, uremic encephalopathy. Endocrinal: pituitary, hypertonic encephalopathy, and diabetes insipidus for the posterior loop, and for the anterior loop, panhypopituitarism, thyroid, hypothyroidism, and thyrotoxic crisis, adrenals, Addisonian crisis, pancreas, diabetes, the 4 types of coma. Electrolyte and acid-base disturbances: increased potassium or decreased, for sodium, hyper and hypo, calcium, hypercalcemic crisis, prolonged convulsions in tetany, coma, severe acidosis or alkalosis. Other metabolic disturbances: mitochondrial encephalopathy, metabolic disorder caused by dysfunction of mitochondrial DNA, Wernicke's encephalopathy due to thiamine deficiency or alcoholism, physical, heat stroke, hypothermia, cardiac causes, cardiac arrest and cardiac arrhythmias, infections, meningitis, malaria, septicemia, and status typhosis. Then we have causes of febrile coma: toxic, aspirin and belladonna poisoning, metabolic, hepatic failure, DKA, endocrinal, cytotoxic crisis, Addisonian crisis, and DKA, physical, heat stroke, fevers, all causes of fevers causing coma, vascular, pontine hemorrhage, subarachnoid hemorrhage, and any type of coma complicated by secondary infection, hypostatic pneumonia. Clinical approach to coma: initial general measures: ensure free airway passages, and ensure enough blood to the brain, maintain adequate blood pressure. History taking: onset, sudden, means cerebral hemorrhage, while gradual means brain tumor, head injury, convulsions, epilepsy, brain tumors, drug intake, drug poisoning, excessive exposure to the sun, heat stroke. General examination: vital signs, mouth, odor, skin examination, and eye. Vital signs: temperature, hyperthermia, causes of febrile coma, hypothermia, hypothyroidism, and morphine poisoning. Pulse: if tachycardia, cytotoxic crisis, bradycardia, hypothyroidism, and morphine poisoning. Blood pressure: if high, hypertensive encephalopathy; if low, Addisonian crisis. Respiration: rapid, deep, DKA, renal failure, and rapid deep respiration is called Cosmos sign. Slow, barbiturate poisoning, morphine poisoning. Mouth odor: acetone odor, DKA, alcohol odor, alcohol intoxication, uriniferous odor, renal failure, fetal hepaticus, hepatic failure. Skin examination: dry skin, DKA, belladonna poisoning; moist, hypoglycemic coma; cherry red, carbon monoxide; needle marks, drug addiction; scratch marks, chronic renal failure, liver cell failure, diabetes. Eye examination: pupils, dilated fixed pupils, unilateral, third nerve compression, as uncle herniation; bilateral, belladonna poisoning; constricted, bilateral, pontine hemorrhage and morphine poisoning; pinpoint. Fundus examination: papilledema in cases of increased intracranial tension. CNS examination: signs of lateralization denotes intracranial cause for the coma. Signs of lateralization are: for the eyes, unequal pupils, deviation of the eyes to one side; for the face, facial asymmetry, motor, Jacksonian fits, unilateral paralysis or paresis, deep reflex and tone asymmetry, superficial reflex, unilateral positive Babinski sign. Signs of meningeal irritation, meningitis, and subarachnoid hemorrhage. Investigations: imaging, plain X-ray skull, features of ICT, intracranial tension, brain tumors, fractures, trauma. MRI and CT scan, the most important investigations. They are very accurate in diagnosing intracranial regions. Laboratory investigations: blood, urine, and CSF, bloody subarachnoid hemorrhage, purulent meningitis. Urine examination: glucose, acetone, and albumin. Blood examination: CBC, leukocytosis and bacterial infections, blood film, malaria, blood levels of glucose, urea and creatinine, bilirubin, blood gases, respiratory failure, toxicological studies, drug poisoning. And finally, treatment: care for the comatose as in hemiplegia, and treatment of the cause. Difference between upper motor neuron lesion and lower motor neuron lesion. For the muscle power, in the upper motor neuron lesion, paralysis or weakness below the level of the lesion, no wasting of muscles, and if present, it's late due to disuse atrophy. Muscle tone, hypertonia, spasticity below the level of the lesion. Deep reflexes, hyperreflexia below the level. Pathological deep reflexes may be present, clonus may be present. Superficial reflexes are lost if the lesion is above the segmental supply of the reflex. Plantar reflex positive, dorsiflexion of the big toe plus or minus fanning of the other toes. Fasciculations are absent. For the lower motor neuron lesion, for the muscle power, paralysis or weakness at the level of the lesion, muscle wasting, early and marked wasting due to loss of muscle tone, hypotonia, flaccidity at the level of the lesion, deep reflexes, hyperreflexia at the level, pathological deep reflexes absent, clonus absent, superficial reflexes lost if the lesion involves the supply of the reflex, plantar reflex or Babinski, plantar flexion of the toes or no response. Fasciculation may be present in irritative lesion of the anterior horn cells. Hemiplegia. Definition: paralysis of one side of the body. Etiology: pyramidal tract lesion at any point from its origin in the cerebral cortex down to C5 segment of the spinal cord. Vascular: stroke, the most common cause. Causes of stroke: ischemic and hemorrhagic. Infective: encephalitis, meningitis, brain abscess. Neoplastic: glioma, meningioma. Demyelinating: disseminated sclerosis, DS or DEM. Traumatic: cerebral laceration, subdural hematoma. Congenital: cerebral palsy. Hysterical: absence of organic pyramidal lesion. Etiology: general and specific. General: clinic, onset and course. It's variable according to the lesion. Acute onset and variable course if vascular, infective, traumatic. Gradual onset, progressive course, neoplastic lesions, remittent and relapsing in demyelinating lesions. Symptoms and signs are variable according to the onset. Acute lesions: the hemiplegia passes through two stages: stage of flaccidity, this is due to neuronal shock, and stage of spasticity. This stage is established hemiplegia. Gradual lesions. The hemiplegia passes directly to the stage of spasticity, stage of flaccid paralysis or shock stage. On the paralyzed side, there are muscle tone completely lost, absent, deep reflexes and plantar reflex, no Babinski sign. Duration from 2 to 6 weeks. If the onset is associated with coma, the paralyzed side is determined by muscle tone asymmetry, deep reflex asymmetry, facial asymmetry. They are the lateralizing signs. Finally, recovery from the shock stage occurs. Muscle tone reappear, then gradual increases. Deep reflexes reappear and gradually increase. Plantar reflex, positive Babinski sign. This means that the stage of spasticity starts. Stage of spastic paralysis, stage of established hemiplegia. Paralysis of one side of the body, shows pyramidal distribution, affecting progravity, weak muscles more than antigravity, which are the strong muscles. In upper limb, extensors are weaker than flexors, and lower limb flexors are weaker than extensors, affecting distal muscles more than proximal muscles. The hand is weaker than the shoulder, the foot is weaker than the hip. Hypertonia, spasticity of the paralyzed side of clasp knife type, affecting anti-gravity more than progravity. So in the upper limb, the flexors are more spastic than the extensors, and in the lower limb, the extensors are more spastic than the flexors. Exaggerated deep reflexes. Deep reflexes in both upper and lower limbs are exaggerated on the paralyzed side, and pathological deep reflexes, normally absent, may appear. Clonus may be present. Lost superficial reflexes and extensor plantar reflex is positive Babinski sign. Gait, circumduction. If the patient can walk, his gait is circumduction due to spasticity of the extensors of the lower limbs. Specific clinical picture. It's variable according to the site of the lesion and the cause of the lesion. According to the site of the lesion causes hemiplegia and may occur at 3 levels. This is called leveling: spinal cord, brainstem, and cerebral. Spinal hemiplegia. It's called Brown-Sequard syndrome. If the lesion is on one side of the cord and exists between C1 and C5 segments, caused by stab wound, disc prolapse, disseminated sclerosis, or tumor. At the level of the lesion, ipsilateral localized lower motor neuron lesion of the muscle supplied by the affected segment. Ipsilateral loss of all sensations in the area supplied by the posterior roots of the affected segments. Below the level of the lesion, ipsilateral hemiplegia, upper motor neuron lesion, ipsilateral deep sensory loss, contralateral superficial sensory loss for pain and temperature, and touch diminishes on both sides. Brainstem hemiplegia, crossed hemiplegia, hemiplegia on the opposite side of the lesion, cranial nerve paralysis of lower motor neuron nature on the same side of the lesion. Midbrain lesion, Weber's syndrome and Bendix syndrome. Weber or Weber syndrome, hemiplegia on the opposite side of the lesion, third cranial nerve paralysis on the same side of the lesion. Bendix syndrome, hemiplegia and hemiataxia on the opposite side of the lesion, third cranial nerve paralysis on the same side of the lesion. Pontine lesion, Millard-Gubler syndrome and Fovell syndrome. Millard-Gubler syndrome, hemiplegia on the opposite side of the lesion, and 6 and 7th cranial nerve paralysis on the same side of the lesion. Fovell syndrome, hemiplegia on the opposite side of the lesion with loss of conjugate deviation of the eyes to the same side of the lesion due to lesion in the medial longitudinal bundle. Medullary lesion, Aviles syndrome and Jackson's syndrome. Aviles syndrome, hemiplegia on the opposite side of the lesion, 9th and 10th cranial nerve paralysis on the same side of the lesion. Jackson's syndrome, hemiplegia on the opposite side of the lesion, 10th and 12th cranial nerve paralysis on the same side of the lesion. Cerebral hemiplegia, hemiplegia plus upper motor neuron lesion, 7th and 12th cranial nerves on the opposite side of the lesion, absence of any cranial nerve paralysis on the same side of the lesion. Cortical, characterized by one or more of the following: coma, convulsions, if the lesion is extensive for coma and irritative for convulsions. Contralateral cortical sensory loss, if the lesion involves the parietal lobe. Homonymous hemianopia, occipital lobe. Aphasia and agraphia in the dominant hemisphere. Paralysis usually involves one limb, monoplegia, especially in vascular lesions. Subcortical, similar to cortical hemiplegia except that the paralysis is more extensive. Capsular, characterized by the following: complete hemiplegia associated with upper motor neuron lesion, 7th and 12th cranial nerves, all are on the opposite side of the lesion. Hemihypothesia on the opposite side of the lesion. Hemianopia may occur, affection of fibers of the optic radiation in the capsule. No convulsions, no aphasia, no coma. According to the cause of the lesion, the most common cause is vascular stroke. Therefore, there should be differential diagnosis between thrombosis, embolism, and hemorrhage. Differential diagnoses are forced thrombosis. It occurs in old age, rapid onset taking hours, prodroma, TIA, transient ischemic attacks, vomiting, absent, consciousness, usually preserved, convulsions may occur, normal and equal pupils, absent fever, high blood pressure may exist, and for the heart, there may be lesions, coronary artery disease, clear CSF, and CT scan with MRI are diagnostic. For embolism, any age, sudden onset taking seconds with prodromal transient ischemic attacks, absent vomiting, preserved consciousness, convulsions may occur, normal equal pupils, absent fever, normal blood pressure, and usually we have valvular lesions with clear CSF. Hemorrhage, commonly in old age, dramatic or apoplectic onset, absent prodroma, common vomiting, with disturbed conscious level up to deep coma in consciousness, frequent convulsions, dilated and irreactive pupils, fever is present, blood pressure is usually high, left ventricular hypertrophy may exist, CSF is bloody with increased tension, and CT scan with MRI are diagnostic. Hysterical hemiplegia, usually young neurotic females. The cause is psychological, no organic lesion. Incidence occurs in the presence of people associated with anxiety, palpitation, and hyperventilation. CT and MRI are normal. Causes of transient hemiplegia, transient ischemic attacks, TOTS paralysis, post-epileptic, demyelinating disease, hemiplegic migraine, and hysterical. And this concludes the neurology.